there are a lot of people talking about TXA, and I felt it was my duty to just start us out in a very simple way and prepare for all the other speakers. And I think I might be asking more questions than giving answers. So I'm going to talk about where we are with TXA, some recently published studies and what lessons we can learn from them, ongoing problems with supply, what can we learn from a protein, because we are using it again, and it's going to give us, it's a good comparator, and then where do we go from here? So I did say I'd start at the basics, so just to remind you that TXA is an analogue of lysine, and it's a competitive inhibitor of plasminogen activation. So by binding to the lysine binding sites of plasminogen, it prevents plasminogen to bind down to fibrin, and therefore TPA can't activate it. And I think that we need to think how important it is. And most of us who work in haematology and in thrombosis and hemostasis are dealing with inherited bleeding disorders such as haemophilia, and don't think about the acquired bleeding disorders, but in fact they are causing major problems. In the same way that thrombosis causes 1 in 4 deaths, justifies our existence, the acquired bleeding disorders are causing a lot of problems. So if you look at the Lancet and the WHO breakdown of deaths every year, there's 55 to 56 million people dying. 9% of those deaths are due to trauma. And when we say trauma, we mean interpersonal violence between civilians and non-civilians, suicides, road traffic accidents. And then buried in the data, there's also a significant number of deaths due to postpartum hemorrhage, accounting for 1 in 200. And most of these are in the low and middle income countries where the status of women is low, and there are a lack of facilities to allow women to deliver safely. And in fact, if we look at the preventable causes of death, bleeding, in fact, exsanguinating, is the #1 preventable cause of death in these areas. And just to remind you, the size of the problem with PPH, we don't really know how many women die because their deaths aren't always registered because of the low status of women in mid-Africa. And this has major consequences. It's usually a woman who is 3rd or 4th pregnancy. She's a little bit iron deficient. She's had a baby every year. She's probably 19. And her uterus doesn't contract down after her delivery. And she just exsanguinates. She may get oxytocin or such equivalent, but blood is a low priority in that setting. So the surviving eldest daughter will not go to school, stay at home and look after the remaining children. They won't have such good nutrition if they'd had a mother who was economically active. And we are losing major income from these women that die and having major socio-economic consequences on the children. So it's a tragedy, and we have to start doing something about it. Now, when we look at the clinical trials that we have with TXA, we are overburdened with them, really. These are the 2 trials I was involved in. So the woman trial was 20,000 women with postpartum hemorrhage randomized to 1 to 2 grams of TXA versus placebo, and CRASH 2, that really started off a lot of the interest and published in 2010, was 20,000 trauma patients worldwide who were given 2 grams of TXA as soon as possible after injury. And what the lessons are from them is that TXA seems to have a predictable effect, in that if you look with this forest plot, you can see that if you get early treatment, which is before 3 hours after injury or delivery, then the deaths due to bleeding fall in a proportionate way in both trauma and postpartum hemorrhage. And yet if you give TXA after 3 hours, and this is happening a lot in low and middle income countries where it takes a while to get to the hospital, it's actually of no benefit. And if we can imagine someone's been bleeding for more than 3 hours, they probably are pretty hypoxic, they've probably got disseminated intravascular coagulation, and that might explain why if you give TXA, they'll have a worse outcome. So this is a different statistical way of looking at the effectiveness of TXA in those situations. And if you look at delay in giving TXA, you are losing a survival benefit of about 10% for every 15 minutes of treatment delay. Now, I want to remind you that when we did CRUSH-2, there was no data to say that there was increased fibrolytic activity in trauma. And it's hard to believe that we got millions of pounds in funding for applying a drug to a situation where there was no basic or translational science evidence. Of course, we're way down the line now. The trauma scientists have really accumulated data. This is some data from London. These are patients coming up to the emergency department, to the Royal London, and they have, this is measuring plasmin antiplasmin complexes. You can see from the top left the injury severity score. The more injury, the higher your plasmin antiplasmin. On the right, base deficit. The bigger your base deficit, the greater your plasmin antiplasmin. Thank you, that's very useful. And then if you are shocked, and presumably you've bled out more, you have the highest plasmin antiplasmin. So the degree of fibrolytic activation in trauma seems to relate to severity. And then unbelievably, we did the woman study, and there was no data on what was happening when women bleed out. We knew from one French paper that the lower your fibrinogen level, if you were bleeding out, the more likely you were to need more blood or die. And we have had this paper, which has sort of come through in the last year, without many people picking up on it, and it does totally explain the coagulopathy of postpartum hemorrhage. So this comes from a husband and wife. This is Peter Collins. He was professor of thrombosis in Cardiff, and his wife, Rachel Collis, who's the head anaesthetist in the obstetric unit. And they have looked at over 500 women who've bled out more than a litre and taken serial samples from them as they bled out, and then looked at the various factors, including fibrinolysis, which Nicola March did. I can't see her here, but we have to say thank you to her. And postpartum hemorrhage is very different from trauma. We have to remember the women have come into labour, they've had an expansion of plasma volume of 40%, their levels of factors are much higher. Factor 8 at term is 200%. And so they've got a lot of prothrombotic reserve on board. Now, what this paper does, it reassures everybody that actually most women who have a litre or two's bleeding aren't going to come to any harm or two because of that hemostatic reserve, and we don't need to throw blood products at them. But there were 12 women, so that's 1 in 1,000 maternities, had a distinct coagulopathy. And what do we find? Well, it's fibrinolytic. And so they called it acute obstetric coagulopathy. And they showed that these patients who had it had enormously raised levels of plasmin, antiplasmin. And here we go again, greater than 40,000. Normal plasmin, antiplasmin is in the low hundreds. And then with that, here we have that low fibrinogen. Remember, at term, pregnant women have a fibrinogen of about 6, much higher than normal. So the low fibrinogen is in that group. So that French study was right. They appear to be getting a coagulopathy. And then when we look at the ratio of Klaus fibrinogen to the fibrinogen antigen, it's altered in those women with a coagulopathy. So the fibrinogen isn't working so well, presumably because D-dimers are interfering with function. And then lastly, factor V levels are much lower in those with acute coagulopathy. And we know that plasmin is a lover of factor V, and so by first we'll go reduce fibrinogen and then really likes the complexity or something about factor V. So this is phenomenal data, because here we have those 500 women bleeding out. They measured the blood loss, and they have given us the levels of the factors as they bleed out. So we've got all of these factors. Here we are, right up here, factor VIII. Well, it's always going to be high. It's an acute phase protein as you bleed out. And then we've got a gradual fall-off of all of the factors. But here, when they bled out 3 litres, they've still got adequate levels of factors. They don't need FFP up front, unlike the trauma patients. There's just one area here. This is a bit dodgy. So we know that at term, women have low levels of factor 13, about 50% of normal, and they're drifting down after they've bled out 3 litres to about 20%. And if you have congenital factor 13 deficiency, that's a trigger for giving factor 13. So we need to know whether we need to give factor 13 to women who are bleeding out. And currently, that's the subject of experiments in Switzerland. And then we come to surgical bleeding. So also a major cause of death. We've got 310 million major surgeries every year globally. I think the USA is the leader in the number, and about 20 million in Europe. And then we have about 8 million people dying after surgery, and we know that bleeding is the cause. So I spent some time in Department of Cardiothoracic Surgery, and it's quite a long while ago, as you can see, and looked at fibrinolysis in the surgical patients that I was seeing. So we have got the dots. This is people going on cardiopulmonary bypass for open cardiac surgery. And then the controls are people having thoracic surgery. So they might be having a lung resection. And what you can see with these old-fashioned assays is that the TPA antigen increases during surgery, and it particularly increases in those who are on cardiopulmonary bypass. It's still, even now, not known why TPA increases during cardiopulmonary bypass, but it definitely does. And there's a thought that it might be binding down to the surface and being activated there. I also had a PhD, Helen Siegel, who would pop over to the liver transplant centre, and we did a trial of a protein in liver transplant surgery. And this data is, we've got during liver transplantation. I think it's changed quite a bit. At that time, you take the liver out of a donor and put it in a bucket, and you'd prepare the patient by removing their own liver, so this is the anhepatic phase, and then you plumb the new liver in, and as we heard yesterday, TPA is produced by hepatocytes. That poor liver sitting in the bucket got very hypoxic, generated a lot of TPA. So as you take the clamps off the new liver, there would be this huge release of TPA into the systemic circulation. You could watch clots dissolve as you were standing there. So what we've got here is, this is what happened normally, and our trial with approachnin counteracted that effect of rise of D-dimer. We also did the euglobulin clot lysis time, very old-fashioned tests, but reasonably reliable. You have a plate and you add your plasma and you look at the amount of fibrin within the plate that gets dissolved. Again, we can see we've got this really good curve showing us that after the liver's been plumbed in, there's a lot of TPA, and to some extent that was counteracted by approachnin. Well, we have had hundreds and hundreds of randomized controlled trials of TXA in surgery, and this is just one meta-analysis. It goes back 10 years. This is looking at 160 trials, randomized controlled trials in all sorts of surgery, hip and knee replacement, abdominal operations, cardiac surgery. What do we find? We are getting a reduction in the use of blood products and also a similar reduction in mortality. And then we all know, we've just been discussing it, that if you give too much TXA, you can get fits. And the fits are presumably because the TXA is interfering with neurotransmission, especially because many have lysine binding sites. But it does seem rather illogical to use a high dose of TXA because it's a competitive inhibitor, it has a plateau effect. So there's no point in giving more than a couple of grams because you aren't getting any more effect. So for me, I like to say it's a near-perfect hemostat for those who are bleeding. So we've got, in trauma, postpartum hemorrhage, we're reducing mortality due to bleeding by a third. And in surgery, we are getting a significant reduction in bleeding. I'm not going to hit on thrombotic side effects, and I know that will be discussed later, but if you look at the recent meta-analysis, in the average patient, there's no increased thrombotic events after the procedure, and we don't see neurological events if you use the standard doses. But we do know from trials such as HALT-IT that if you give prolonged TXA, you do get increased rate of VTE. Well, such is the recognition it's safe and it's efficacious that our National Institute of Clinical Excellence says, will you please use TXA if you're expecting bleeding during surgery? And the hospitals have to return audits to show that that is happening. And similarly, that applies in trauma. You're meant to be using TXA in those who are bleeding. But a lot of this data is old, and we are now in a different place and a different way of thinking. And I like to think that we want to think about precision in how we deal with our patients. And this is an editorial I wrote with Matthew Neal saying we need to really look at situations and come up with how to manage them. And we were particularly worried about obstetric postpartum hemorrhage guidance. They almost always say give fresh frozen plasma up front, extrapolating from the data that exists in trauma, having not seen the study by Peter Collins. So could we actually improve the clinical outcome with TXA? Is it worth it? Is it cost effective? We haven't really asked that question. So we know that an individual in response to trauma, surgery, postpartum hemorrhage will have different fibrinolytic responses. Could we have a look at that? Could we monitor the TXA and make sure that that individual gets maximal effect? Will that actually make any difference to the clinical outcome? And then the other issue for me, because I'm more a thrombosis doctor now than a bleeder, is we know that as soon as we come to the end of surgery, the patient flip-flops to a hypofibrinolytic state. Are we using TXA for too long? Should we stop it at a much earlier time so it doesn't come over that time of hypofibrinolysis? There's lots of papers looking at the variability of response. This one is by Tim Coates, who was involved in CRASH 2, and these are the levels of TPA of patients who've got bleeding when they come to the trauma department. So very variable. And you could imagine with this heterogeneous response, we've got different heights of TPA. It lasts for longer or shorter times. And we know we've got genetic differences in our levels of TPA. Our effect of PI1, the 4G, 5G mutation, means that some people have more powerful fibrinolytic effects. And then we have diabetes and obesity, where we've got adipocytes producing PI1, and then also the type of injury. So this comes from some work, again quite old, from Camp Bastion that we did with the British Army, and we looked at the extent of fibrinolysis in different injuries. So in Camp Bastion, this is the Afghanistan war, we've got gunshot wounds, and then this is blast injuries. This is usually somebody who's trodden on a mine, and so they have all of their lower limb tissues shredded. And they have much more evidence of increased fibrinolytic activity. And then this is from experiments in rats, showing that after the rat has had a period of trauma, the active TPA over active PI1 ratio changes very quickly within 60 minutes. And I suspect this is true in adults too. So I would argue that we need to stop the TXA earlier. And then the recent studies are telling us when not to use TXA. It seems obvious, doesn't it? If you haven't got any fibrinolytic activation, why would you give it? And yet, I have tried to point out to you, we've done all these enormous trials that have cost millions and millions without asking the question first, is there fibrinolytic activation? And we've come to a bit of a cropper with the last few trials. And really, I think the basic scientists ought to be involved at an earlier stage to say, yes, this is a situation where we've got increased fibrinolytic activity before we do the trials. It's like putting the cart before the horse. So we've got lovely work in women having vaginal deliveries, saying if TXA might reduce blood loss. Almost did, but then it was a lot of work. And then this last week, we've had the Woman 2 study produced, and that's for women who are anemic when they go into labour. This is in 4 countries, in low and middle income countries, Nigeria, Pakistan, Tanzania and Zambia. It was very quick to recruit, and they gave a gram of TXA post-delivery to see whether it might reduce the rates of postpartum hemorrhage. And the answer, after all that work, is, if you look at the bottom, there was no decrease in the rates of postpartum hemorrhage. And if you look at any data, because there isn't any basic science data in this area, apart from this study from McKinnon in 1987, which showed if you look at women who come to delivery with some very old-fashioned assays, there's no incidence of increased fibrinolytic activity. And I'm rather ashamed about this because this I did about 10 years ago in a series of Greek women, and they had normal deliveries. I really didn't have a significant rise in TPA activity. So I should have published this. And there is no evidence of fibrinolytic activity in normal delivery. Well, we need to think how wonderful TXA could be if we gave it to everybody who had a traumatic bleeding problem. We could save 128,000 lives if people actually received it. But there's major difficulties in supply in low and middle income countries. And when we look at access to TXA, it's started to be noticed. The Clintons have got in there, the obstetric people have got in there, and they're saying in most countries in Africa there is no access to TXA, and it's such a simple and cheap drug to use. And if you look at where TXA is produced, which has been mapped, most of it's coming from India and Pakistan, Europe, some places in America, but really no factories in Africa. So if we look at what's happening in the different African countries, so look at Chad. 1 in 1,000 women are dying when they give birth. Extremely high maternal mortalities. Nigeria's pretty much up there, and yet when we look at whether they can access TXA, well, they've got access in Nigeria to 2 products, but somewhere like Central African Republic, they don't have access at all. It's just not registered. There is nobody producing it. So the plans are that these big organisations with money will help set up factories, make sure there's quality assessment, and make TXA available in some of these countries. Now, I'm coming to the end. I just wonder whether we cannot improve on the efficacy of TXA and think about the lessons we have from aprotenin. So aprotenin is produced in bovine lungs, and it is a Kunitz-type serine protease inhibitor. It will bind with chymotrypsin plasmin, also at very high concentrations with thrombin, and it also will inhibit kallikrein. And what happened to aprotenin was in the 80s, there was some interest in giving it after cardiopulmonary bypass and a little shock before in reducing the incidence of shock lung. And when that happened at the Hammersmith Hospital in London, they noticed all the surgical fields were dry and they could finish the surgery earlier. And they went back and showed that the blood loss was much less. So this led to more trials and licensing of aprotenin to reduce bleeding. And at the time, they thought that it was the inhibition of kallikrein that was actually responsible for reducing the bleeding. But after quite a while, I haven't got time to go through that, it was shown that it was probably the antiplasmin effect of this rather dirty inhibitor. And there were many randomized controlled trials showing it reduced bleeding, mainly in cardiac surgery. But all along, safety has been an issue because it's a bovine protein. You need to give a test dose. You might have an allergy to it because it's a bovine protein. And the other issue was it was compared up against TXA and EACA, and it appeared to have a higher mortality. So it was withdrawn, and now still available where benefit outweighs the risk. And I know a lot of cardiothoracic anaesthetists still use it with a very high-risk patient, and certainly my unit does too. So where should we be going? Should we be aiming for more personalised TXA, which might improve its clinical benefit? Or should we be thinking about someone synthesising a better drug that maybe is just an antiplasmin agent and doesn't have all the other inhibitory effects of aprotenin? Or is it that TXA is so good because it's just suppressing plasmin production partially, allowing it to have some other effects, and that makes it safe? Because if we totally inhibit all plasmin, what will that consequence be? Well, my thank you, this is my last slide, is to the amazing discovery of TXA in Japan. Tetsuo, have you spelt her name correctly? I'm a bit dyslexic. So there she is, a real feminist working in the 1950s after the war, dedicated to trying to produce a drug to reduce bleeding in women. As you can see, there's her daughter in their lab. This is their lab at home. They couldn't work anywhere else. And she was also wonderful in that she noticed lots of scientists had children with them, and she helped establish nurseries for the children. So really, it's a thank you to Yutaka Okamoto, who brought us all here today. Thank you for listening.